So how you will approach to a patient with AKI? So full history, we have been always discussing the importance of history, why history taking is important. So exposure to any of the nephrotoxin or drugs if the patient is being exposed to. And urea may indicate post-renal causes that we talked about, BPH, urethral obstruction. Skin rashes, if it is being there, it can indicate any allergic nephritis disease. Look out for the volume depletion signs if the patient is having diarrhea or any bleeding. Do a pelvic and perrectal examination. An ischemia or trauma to legs or arms may indicate rhabdomyolysis. There is muscle breakdown. There is creatinine loss from the muscle. Prostatic disease, nephrolithiasis. Recent any surgical or radiological procedure, whether it has been done. Past and present use of medications. Family history of renal diseases which has been there. So when we look at the physical examination, it should be focused to rule out the differential diagnosis. Very important. Pre-renal cause, we have discussed what will be the clinical signs and symptoms in a pre-renal AKI. All this hypotension, congestive heart failure signs, volume signs. Acute allergic interstitial nephritis is suggested by signs of allergy. And what will be the signs of allergy? Eosinophilia, wheezing, maculopapular rash, or periorbital edema. Lower urinary tract obstruction suggested by what? If there is a flank mass, symptoms of bladder dysfunction, suprapubic mass, if there is hesitancy or urgency of the urine. So what will be the diagnostic workup of a patient of AKI? The first, urine analysis, macroscopic evaluation of this urine sediment. So we have discussed the differential diagnosis of the urine sediments, whether it is a red blood cell cast, whether it is a white cast, whether it is, brownish pigmented cellular cast, and what exactly this cast it can suggest. So pigmented cast without erythrocytes in the sediment from urine, but with positive dipstick for the occult blood can indicate hemoglobinuria and myoglobinuria. And also along with this, you can do a LDH levels, CPK, MB levels. This can indicate any hemoglobinuria, myoglobinuria, or if there is a muscle breakdown, rhabdomyolysis is being there. Dipstick test, trace or no proteinuria with pre-renal and post-renal AKI. So mild to moderate proteinuria with ATN and moderate to severe proteinuria with glomerular diseases. RBC and RBC cast in glomerular diseases. Crystals, RBC and WBC in post-renal ARF causes. The second workup, urine and blood chemistry. So most of this test helps to differentiate pre-renal azotemia, osmolality or specific gravity decreased in ATA and post-renal AKI, while increased in what? Pre-renal AKI. Why this specific gravity or osmolality is decreased? Because in post-renal AKI and ATN, the urine is diluted as compared to the concentrated urine in a pre-renal AKI. BUN by plasma creatinine ratio, normal at 10 or 15:1 in ATN, but 20:1 in pre-renal disease. Why? Because there is passive reabsorption of the urea. There's a high ratio. If it is being there greater than maybe 15-20, it can suggest pre-renal disease. But this is not a very specific and sensitive criteria. BUN by plasma creatinine ratio. Renal failure index is to ratio of urine sodium to urine plasma creatinine ratio. So urine sodium by urine creatinine is to plasma. Values less than 1 are consistent with what? Pre-renal, whereas greater than 1 will suggest acute tubular necrosis. Fractional excretion of sodium, ratio of urine to plasma sodium ratio to urine to plasma creatinine, expressed as percentage. So urine sodium by plasma sodium divided by urine creatinine to plasma creatinine multiplied by 100. So if this value is less than 1, it is a pre-renal, and greater than 1, it is a ATN. Then comes the role of radiography and imaging. Ultrasonography, again, it will help you to assess the kidney shape, size, whether it is an ectopic kidney, where is the presence of the kidney is being there or not, whether if there is any hydronephrosis, hydroureter. It will also give you evaluation if there is any stones, renal calculi, if there is any renal vein thrombosis, which is being there or not.